In this audio lecture, we're going to be talking about pleural effusions and pneumothoraxes. Both are disorders that affect ventilation. Again, this ventilation is going to be getting air to the actual alveolar membranes for exchange surfaces. So we're going to cover pleural effusions first. And pleural effusions are when you get a buildup of liquid inside the pleural cavity. So if you think back to anatomy and physiology, we had this pleural cavity that was in between the thoracic cavity and the lung. Okay, so this pleural cavity actually had a negative pressure associated with it, which keeps the lungs inflated. Okay. When the pressure increases in the pleural cavity, the pressure also increases in the alveolar cavity, which in turn increases over atmospheric pressure. Right? So if we get changes in this pleural cavity, it could affect whether or not the lung is actually inflated or not. Okay. So this fluid that accumulates in the pleural cavity, so if we look at this lung here, we see this black region, and we also see this other region that's white. This white region is not as dense, and what has happened is we get pleural effusion building up here, which collapses this part of the lung. And so we see the black parts are the parts that are ventilated and being perfused, and then we see the white parts showing up as really this white substance because it's not as dense as everything else around it. So if these pleural exudates, the pleural effusion can be made up of numerous substances, including exudates, like interstitial fluid, blood, and pus. So this can impair breathing quite substantially. If you have any pressure on your lung, then you can inflate that part of your lung. And so we might see this result in pleurisy, which is inflammation of the pleural membranes. And if we get inflammation of the pleural membranes, that might worsen the effect and increase the amount of pleural effusion. So the manifestations for pleural effusion, here's a better picture if you guys are having difficulty visualizing it. So we get the space building up between the pleural membrane. So this is the parietal membrane, and then the part that would interact with the organ is the visceral membrane. And we see that really the buildup of fluid in here is ended up increasing the pressure on the lung, collapsing it instead. So the manifestations for pleural effusions can include labored breathing, otherwise known as dyspnea, chest pain, tachypnea. So if you have a lung that is being compressed and it isn't being fully oxygenated, we might try to breathe faster to reach that same oxygenation level in our blood. So we could see tracheal deviations, absent lung sounds over the area where it's affected, right? So we might not be able to hear the lung inflating if this is all just water here and it's not actually moving with chest movements. Okay. Tachycardia, just like we just kind of explained. So for the same reason why you would see tachypnea, we're going to see tachycardia, right? So if we're transporting less oxygen, we're going to then beat our heart more quickly to oxygenate out more. We might end up resulting in a pleural friction rub. So now, since this pleural membrane may become inflamed, now it's going to in turn probably generate some fibrous tissue, and this is going to generate friction, and it's going to really counteract the effect or the function of the pleural membranes, and that is to lubricate chest movements, right? And to make sure that the lung, as it moves, doesn't get stuck on anything. Now we might get fibrous plaques start developing. So treatment of pleural effusions, we're going to start with a thoracentesis. So this is a removal of the fluid that is building up in the pleural cavity. Okay. We might place a chest drainage tube to drain out any fluid that is in that pleural cavity. Obviously, this would need to be maintained sterile to prevent bacteria from growth in it. We might give antibiotics if the pleural effusion is due to an inflammatory event that causes pleural effusion or production of exudates. So Now we're going to talk about pneumothorax. And so pneumothorax is quite the opposite problem, or the rationale, but it still has the same effect. And so what a pneumothorax is when we get air inside of the pleural cavity, and this compresses the lung, right? So this buildup of air in here can actually cause the lung to actually collapse, because now pressure increases in the pleural cavity, and it's much higher. Usually the lung, in order for it to stay inflated, needs to have a higher pressure. Instead, we start to see the pressure build up higher on the outside, and then it compresses this lung tissue by pushing the air out. So some risk factors for pneumothoraxes can be smoking. Obviously, if we cause damage to the connective tissue of our lung, that's going to compromise it a little bit. If you're tall, right, we can see that if you have a history of lung disease or previous pneumothoraxes, lung disease might include like emphysema or chronic bronchitis, anything that is really going to weaken the alveolar walls. Okay, so a spontaneous pneumothorax is due to a leak in our system. So now our lung actually has a hole in it, likely, and as this lung has a hole in it, every time we inhale air, air is moving into the pleural cavity, right? So as this air is moving into the pleural cavity, then it is increasing pressure of the pleural cavity, and this is applying pressure to the lung, right? And so now this pressure that is entering the pleural cavity, since the lung no longer has a greater pressure than the pleural cavity, the air is moving into the pleural cavity. This increases the pressure there, resulting in collapse of the lung. So this is a result of a weakening of lung tissue, and so because of a couple of reasons, but really we get this weakening and we get a bleb forming, and so this bleb forms, then air moves into the pleural space as it ruptures. Usually it's fairly mild. In instance, it sounds pretty serious, but this is pretty mild, and it can be corrected fairly easy. Okay. Then we can have a spontaneous pneumothorax, secondary spontaneous pneumothorax, which is caused by a secondary underlying disease, like lung disease, emphysema, COPD, chronic bronchitis. And so any of these disorders can cause a secondary bleb and then a pneumothorax as a result. These are more severe and more life-threatening, because here we have several conditions, and we have weakened alveolar walls, and so the leaks might be more substantial. We see weakening of the structures, in addition to maybe emphysema. So, for example, we have a decreased gas exchange surface. We have a decreased ability to recoil. So we have multiple disorders in this case. So we could also have traumatic pneumothorax, like being pumped in the chest when you get in a car accident, the airbag explodes or it opens up. Any kind of penetrating blunt trauma surface to the lungs can actually cause the lungs to actually collapse on themselves because the pressure is increasing. Or we could have a tension pneumothorax, which is the most serious type, because this is really a positive feedback cycle, and it keeps on perpetuating itself. So as you can't get a good breath, and so you inhale a little bit more, and then all the while this tension pneumothorax is due to a hole coming from the outside. And so the hole from the outside, as it pulls air inside the pleural space, when you expand, when you exhale the air, it pushes this flap back shut, and so no air actually moves out, it just moves in through this hole. And so when you expand it, air moves in, and then you start to expel air, and now it's just increasing the pressure, further causing the problem, right? So there are ways to address this in the wild. So in the case that you have a first response wilderness training, they actually tell you to tape trash over this hole, and what it does, it creates a suction, and it's a one-way valve, so you tape down 3 sides of it, and then it allows air to escape but not enter, because it does the same thing as this valve does on the inside. But in this case, so the alveolar pressure is no longer greater than the pleural pressure, and actually it's the atmospheric is less than the atmospheric pressure, right? So this is a problem because now air voluntarily wants to go in here because you're squeezing this balloon, essentially. You're squeezing the air out of it, and so you could get severe lung depression, function depression. Okay. This can cause the heart to shift over to the left side or the right side, and depending on how it affects. Usually it is the left side. So some manifestations of pneumothorax are going to be sudden chest pain, chest tightness, because now really air is being trapped on the one side. Dyspnea, labored breathing, tachypnea, rapid breathing, decreased breath sounds over the affected area, just like we saw with pleural effusions. Asymmetric chest movements, right? So one side of your chest might, as you expel air, might go down, whereas this side on the other side may not, right? We can see that you see deviation of the trachea and mediastinum. So that's going to shift a little bit. Okay. Because you can't catch your breath, we're going to see anxiety, really anxiety occur, but tachycardia would also follow suit because the decreased oxygenation of your blood. Pallor, right? Because now we're going to systemically vasoconstrict, and then hypotension, which would decrease our blood pressure. How are we going to diagnose pneumothoraxes? Chest history and physical examination. A chest X-ray is going to allow us to identify it, so we can see this pleural effusion right here, or a pneumothorax. The air has gotten into this side and is compressing this lung. This is the vascularized part, which is why it's showing up black. Okay. We could use computed tomography to get a 3D picture. For arterial blood gases, we might expect that we would have a decreased partial pressure of oxygen. So how are we going to treat this? We're going to try to remove that air, right? And so this we want to reestablish this negative pressure that keeps this lung inflated in here, and so the pleural cavity will have the air removed, so it's not having this higher pressure atmospheric air inside of our pleural cavity. And includes a thoracentesis in case fluid buildup has also occurred, and chest drainage tube is going to, and if it is air, you might put in a one-way valve to allow the air to move in one way. Now, when we surgically repair these things, oftentimes we get scar tissue formation, and that is called pleurodesis, and this allows a strong patch essentially to be deposited over. So as you replace as you're fixing the membrane, the scar tissue is going to grow over, and scar tissue is generally a lot stronger than what was there before. It just doesn't have the same function. So the elasticity of your lungs might be compromised in that area, but it is going to be stronger. And if it is when it was susceptible to breaking before, it might not be anymore. Alright, with that said, that is the end of our pneumothorax and pleural effusion audio lecture. Both of the conditions end up compromising how much gas exchange can actually occur between our blood and the respiratory surface. So, alright, until next time.